just to briefly look at the ethnic composition of New Zealand, and again, remember this is based on 2006 data and things have changed. And in fact, I was just, because someone mentioned this last week, I was looking at the population projections for New Zealand because there is some projections based on ethnicity as well. So you can see this is 2006, but 2026, just from memory, if you lump in the European and other, that'll be about 61% of the population. Māori is pretty much what it is there. Pacific peoples is, I think it's about 12%. Chinese Asians about 15% of the population. In 2026, so for Auckland, it'll be 35% of the population. The Indian Asian increases a bit, but not a lot, and the other ones stay fairly constant. But there is going to be a pretty significant change in the number of Pacific people and Asian people across New Zealand, but predominantly those changes will be in Auckland and counties Manukau. But in saying that, the Asian population is increasing all around the country, particularly in the main centres, so it's something to keep in mind. The religious affiliation also is quite interesting. New Zealand has quite a wide range of religions. This isn't all of them by any means. You can see that the combined Christian denomination is about half the population, and then the other ones taken fairly small percentages. But interestingly, the number of people who put down that they had no religion in the census was 31.5%, which is actually very high. In Australia, it's about 19% of their census, and in the UK, it's even lower. I think it was about 11 or 12%. So just to think about that as well in terms of the kind of spiritual care that people might want or need at the end of life is quite interesting. This is also interesting as well, the number of people who live in a single-person household. So in New Zealand, that's in 2000. This is based on 2006 again, so it's probably different now. 328,000 people living by themselves. So they may not have access to an informal carer network or informal carer. Single-person retired household, so that's someone who's aged over 65 and not working. 118,000, or other retired households, so that's people who are over age 65 or at least one of them is retired. And the residents of aged care facility in 2006 was almost 26,000, and that is a bit higher now. But those, particularly the top groups here, are people who may or may not have easy access to informal carers, may have issues around their financial situation as well. And of course the aged care facility people have implications because probably all of those people are going to die there. Around a third of our population die in residential care. So access to good palliative care there is really important. So I looked at deprivation as well, and I will try not to make this too complicated. I've explained this in a fair amount of detail in the report because it can get a little bit difficult to understand, but essentially in New Zealand, deprivation rankings are based on information from the census. There's a list of information taken from the census and use those to work out, based on small areas, what the relative deprivation is. And the small areas are very small, they're called mesh blocks, but they put them all together to make it what's called a census area unit. So within DHBs, there's a varying number of census area units depending on their population, because it's a minimum population of 100 in a unit. But in order to make some sense of it all, what I did for this analysis was take all the census area units in a DHB and look at what percentage of each one fell into the different deprivation quintiles. So 1 is the least deprived and 5 is the most deprived group. So what I'd aim to do is give you an overview of what deprivation is like within a DHB. There is some data, but it's fairly limited on how deprivation influences the level of need. And St Christopher's Hospice did a study in London and showed that those in their catchment area with the most deprived area needed at least twice as many visits a week compared to the least the least deprived. So for areas in New Zealand, you may extrapolate that to say that areas with a high level of deprivation might need more resources to meet the needs of their population. I don't know how well you can read the DHBs, but they're listed down this side here, starting. It's kind of from the top of the North Island to the bottom of the South Island. At the very bottom is all the DHB population put together, and it actually comes out exactly how it should do. There's 20% in each deprivation group. But you can see that across the DHB there's a very wide variation. So this brownie colour is the least deprived, and this very light blue colour is the most deprived. So if you compare, probably Waitemata have quite a large group that is in the least deprived and a fairly small group in the most deprived, to Tairāwhiti. Small group in the least deprived and a very large group in the most deprived area. So that DHB population, even though it's much smaller than Waitemata, has a much larger population who are living in more deprived condition or situation. So it's just illustrating how that varies across the DHBs. And it's another thing that needs to be taken into account when you're looking at how you're going to care for your population. But it's also worth thinking about how resources are allocated around the country, because in somewhere like Tairāwhiti, the population is predominantly rural, widespread, relatively high deprivation. So what sort of resources do they need to a more densely populated area with the higher, with the less deprivation? That's open for debate. I'm not going to say what that might mean. How much time have I got? I haven't got a watch on. So that's a bit of a brief overview of the population demographics. Now I want to talk about estimating the palliative care population, or how many people there might be. So the whole of this needs assessment is actually based on a methodology from the National Council for Palliative Care in the UK. But when it came to doing the estimates, we've deviated a bit and actually used a model from Western Australia that looks at providing 3 different estimates, which will allow you to look at a range of resourcing implications, but also to come at it from some different perspectives about what you think might constitute the palliative care population. So there is a minimal estimate group, and this is based on specific disease codes, which is based on the ICD-10 coding system, which is how we code diseases in New Zealand and internationally. So this is condition specific, and it will only include diseases that are in the estimate group. So for adults, there was actually, I think, 11 different diseases, and that was cancer, respiratory disease, heart disease, several neurological diseases, HIV, AIDS. For the children and young persons group, that list was taken from a survey of palliative care patients in the UK of children who are seen by palliative care services. So the list of diseases is much bigger. It's about 120 different diseases, I think. So that's very disease specific. The mid-range estimate has a different approach, and the people included in that estimate were people who had a hospital admission within 12 months before they died, and the reason that they were admitted to hospital, the diagnosis code for that matched the diagnosis code for their cause of death. So the implications of this group is that they had an identified illness, they were in contact with the health system already, and the fact that they had a hospital admission for the same reason that they died implies that there was a need related to their disease or condition. The maximal estimate is basically everyone apart from those who died from causes where palliative care probably wouldn't have been of any use, so if it was an accidental death or a sudden death, where there was basically no time to provide any palliative care. And it represents the ideal situation where everyone who is known that they're going to die receives palliative care. Does that make sense? So this is the adult estimate based on those 3 different groups. So in the figures used for these estimates is based on an average cost 3 years worth of mortality and hospital data, which is 2005, 2006 and 2007 to give or to try and iron out any ups and downs in deaths across the 3 years. And so the all deaths is taken as an average across all deaths across those 3 years as well. So all adult deaths, 27,257. Taking the different approaches to the estimates I'll just go to the bottom, so we separate into cancer deaths and non-cancer deaths, but if you look at the bottom row, if you can actually read it, the minimal estimate shows around about 11,390 people, or 42% of all adult deaths. The mid-range estimate is just about 15,500, or 57% of all adult deaths. And the maximum estimate is 94%, just about 25,500 people. So that shows you there's quite a big range in the estimates based on those different criteria. And you can see that the number of non-cancer deaths increases across those groups as well. And that's because the first one includes all cancer deaths, the maximum will include all cancer deaths because they're not accidental ones. And the mid-range includes quite a wide range of diagnoses because there's no criteria for what the diagnosis for cause of death was. And then for children, the same thing. So the minimal estimate, 287 with the specific criteria. The mid-range, 272, so not too far different, and the maximum, 388. And so that's about 60% of all deaths for children and young people, and the reason that they didn't all make it into the maximum estimate is because most deaths in that age group are accidental or sudden. So one of the things we had to decide was what estimate will be used to look at the characteristics of the population that would benefit from palliative care. So looking at the literature and discussing with the advisory group, it was agreed that the mid-range estimate probably represented the best number for people who benefit from palliative care because it's based on, or more closely based on need. That group of patients is already known to the health system, so they're more likely to be able to be referred to and access palliative care. They're known to have what is probably a life-threatening or life-limiting illness. So they're the group that we've used to analyse as our most likely palliative care population. This slide just shows some estimates into the future, so projected estimates based on the number of deaths per 100,000 using the mid-range estimate for adults and children. So our estimate was 15,452 adults, which is 518 deaths per 100,000 of the population. So projecting that to populations in 2060 and 2026, you can see that it increases by about 2,000 people each 5 years, 10 years, 10 years. Children doesn't increase a great deal because their population is fairly low compared to the number of older people that are going to be coming in those future years. But also, their estimate's not very big anyway, so we wouldn't expect to see a great big increase. So just to highlight some of the key things about that mid-range group, this is the number or the proportion of deaths in that group and age. So it's age group on the bottom and the proportion of the mid-range estimate that they make up, and it's very similar to the shape of the mortality curve. So as mortality increases as people get older, basically. Funny, yeah. But essentially what that means is that if we take this as the people who should be receiving palliative care, most of them are going to be over age 65. There is a blip you'll see down here in the 0 to 1 year olds, and that might make a bit more sense when you see the cause of death, but essentially there's, in the paediatric mid-range estimate, there's a lot of perinatal deaths and deaths from congenital malformations, deformations, and they're all in pretty much under 1 year olds.